this early morning session on the last day is a very important session that you must realize. And what I see in the program, total program is 75 minutes. 12 speakers are there, 6 minutes each, 72. So there is no time even for changeover. So I will request that everyone should stick to their allotted time, number one. Number two, the next speaker who is in line should be there on the other podium, ready before the first speaker finishes. In case if we get time at the end, then we can have discussion. Otherwise, there will be, because there is no time for question. The organizers have not made this, those people who have made the program have not kept any provision. Although it is written 5 minutes discussion, but then otherwise also it becomes 77 minutes. So I don't know who made this program. Yeah, so the first speaker, Bulaiye, Mathur Sahab.
So we invite Dr. Manas Nath here. Yes, sir. He will be speaking of MSICS in traumatic cataract. Next speaker is Manisha Rathi, is not, I can't see here. So next is Nilupatana, she's here. Yeah, so you get ready here this time.
Good morning, sir. Thank you so much for being here on a Sunday morning. And I'm really privileged and honored to be presenting Dr. Boramani's customized small incision cataract surgery. So as you can see, surgically induced astigmatism can be used by us to convert to surgically corrected astigmatism. So in this patient with 0.13 preoperative astigmatism, there was a final astigmatism of only 0.17 diopters. The corneal topography has been done for documentation and to prove that the astigmatism was minimal. In this patient of 2 diopters of preoperative astigmatism, the final astigmatism was only 0.43 diopters because of his customized incision. So what are the factors? What is the algorithm that Dr. Boramani has developed and follows? The length of the incision, the site of the incision on the steepest meridian, and the shape of the incision is what determines the final post-operative astigmatism, because the need of the hour is best uncorrected visual acuity. And as you can see, although there may be keratometric and corneal topography astigmatism, if it is minimal, the patient does not require any correction. Scleral tunnel incisions are more kind in nature. They are secure, they heal well, they're forgiving in the sense that in the beginning, when the residents are not in the correct plane, they can start from the other side and secure a great tunnel. It's an economical, affordable, effective surgery. So depending on the shape of the incision, the straight incision gives us the maximum surgically induced astigmatism, which can be used to modulate and correct the pre-existing astigmatism. So a typical superior straight incision gives 1.25 to 1.5 diopters of astigmatism, slightly curved 0.75, more curved 0.4, and highly curved almost U.2, whereas a perfect U gives 0 astigmatism. It's difficult to make, but it gives great results. Depending on the length of the incision, a 7 millimeter incision gives an astigmatism of about 1.7 diopters in the superior area. 6, it reduces to 1.25, and with 5 millimeters, it's reduced. So the size of the incision, shape of the incision, and most importantly, the site of the incision. The superior curved incisions, as you can see, the straight gives the maximum SIA. It reduces as the incision starts getting more curved, and finally the perfect U gives 0 surgically induced astigmatism. Temporal incisions are weaker in this regard, and they afford less surgically induced astigmatism. So the surgery can be tailor-made, hence it's customized. Depending on the need of the patient, you can use this astigmatism, which was initially thought a curse, can become a blessing. So the straight temporal incision gives a much less astigmatism. The straight temporal gives 1.08, whereas the straight superior gives 1.7 diopters of astigmatism. Straight 6 millimeters, 0.53, and 5 millimeters gives less astigmatism. Temporal curved are even less. So with a minimally curved, you get 0.26 diopters, and with the frown, you get 0.2 diopters of astigmatism. Depending on the incision type, supratemporal straight gives 0.6 diopters of astigmatism, and a supratemporal frown gives half of that, about 0.3 diopters. Supranasal is more difficult to make, but may be required in certain cases, yields excellent results, 0.47 diopters. So in case the steep meridian is 140, the incision, as you can see, must be centered on the straight meridian. Depending on how much correction you need, the shape of the incision, so maximum correction with the straight incision and maximum with a longer incision. This is the area that we have to make the incision, the left eye and the right eye. And these are available SIA calculators online. There are various ones. So Dr. Boramani's work over decades has shown that the final results give minimal surgically corrected astigmatism. And the pre and post of corneal topography, you can see that if it is minimal, you can curve the incision more, so as you can keep the minimal astigmatism, and the steep meridian should be the center of the incision in these patients. This is one patient with special mention, an optometrist mother who had 3.5 diopters of preoperative astigmatism in both eyes. In one eye, she had had phacoemulsification at a premier institute and had residual astigmatism of 3.5, and she was not happy with the outcome. So he discussed all the possible surgical options with her, and she selected CICS by Dr. Boramani, and this is the final astigmatism was only 0.64 diopters with correction of 2.98 diopters. And how was this achieved? With a straight 7.5 millimeter incision on the steep meridian. Another case with high astigmatism 3.3, you can see that a straight incision has been used to give final minimal surgically induced astigmatism, maximum surgical correction of astigmatism. This is another patient. So the moment it crosses 1 diopter, then a straight incision is given on the steepest meridian for best results. And as you can see, the post-operative refraction, there is no acceptance of glasses. The patient is happy, surgeon is happy, and ISMS-ICS is happy. So all these examples that are shown, the moment it goes above 1 diopter, sir goes for the straight incision. So we should start saying surgically corrected astigmatism instead of surgically induced astigmatism now. And this is the reference making and axis marking, which is done with the patient in the sitting position, sitting up, so the effect of gravity is not there. And now you can see that the 39 meridian and 70 meridian is, with the marker, the incision is being planned and given. The measurement will be done. In one of them, we require a straight incision, and the one on the left-hand side with 70 degree, you require the curved incision. So it's always better to mark, to measure, and to deliver the best results for the patient. A straight incision on this side is required and a frown on that one because less correction is required. And this data has been published in the prestigious Indian Journal of Ophthalmology. There is a margin of error of 1 diopter because over or under correction by 0.5 is still acceptable to the patient and gives great results. With customized tunnel engineering, we can remove our tunnel vision to say that SICS is not a superior surgery, and it's possible to wipe out or utilize the astigmatism to minimize the stigma of ATIS. Thank you so much, sir.
Thank you, Dr. Manisha. Dr. Manas, are you ready? Dr. Manas, are you ready?
Yes, sir. Yeah.
So
Thank you. I'll be talking about management of traumatic cataracts with manual small incision cataract surgery. I'll be showing few videos here. This is the first video of a blunt trauma with ruptured anterior lens capsule, which on staining is looking like an Argentinian flag sign. So this tear is converted into a partial capsular excision on both the sides, and as the status of the posterior capsule was not known, I avoided in hydro procedures, and just with the help of viscoelastics, I prolapsed the soft nucleus out of the bag and out of the eye as well. So as I've used viscoelastic throughout, chamber was well formed, and at the end when the PC was found to be intact, a lens is placed in the capsular bag, which was found to be well centered. This is another case of inferior subluxation of around 4 clock hours with nuclear sclerosis grade of around 3 to 4. So here I have fashioned a superior sclerocorneal tunnel. The architecture of the tunnel should be very good, otherwise the chamber will collapse now and then during the surgery and can compromise the surgery in the form of vitreous prolapse in the anterior chamber. So fashioning or aiming for a capsular axis of at least 6, and then after doing visco dissection, supported the bag with 2 iris hooks and a CTR. One can always use a capsular hook. And then after doing hydro dissection, nucleus prolapsed and the lens is placed in the capsular bag. There is one more case of inferior nasal subluxation of around 6 clock hour, and one can see that the wrinkling on the anterior lens capsule suggesting gross zonular weakness. So after fashioning a temporal sclerocorneal tunnel, I have initiated my capsular axis with cystitome. The grade of the cataract is almost 4+, and now switched over to Utrata forceps for better control. As the size of the capsular axis was not adequate as compared to the grade of the nucleus, I did a partial double axis here, and then supported the bag with 3 hooks and CTR. And after that, I've done a dissection and delineation. Delineation will reduce the size of the endonucleus, which can then be prolapsed biminally. So in biminal prolapse, the Sinsky goes towards the equator, pushes the one pole out, below which the second instrument is or spatula is placed, which will act like a fulcrum, and over which the nucleus will be dialed out. And then after removal of the nucleus, after removing the cortex, as the bag was very weak, I decided to implant a CTS and sutured it to the sclera, and a single piece lens is placed in the capsular bag. There is another case of anterior subluxation of lens where almost 2/3 of the lens was in the anterior chamber. So I decided to go for intracapsular cataract extraction combined with SFIL. I usually prefer the Gabor's sutureless technique. So for that, I begin with fashioning the Chariot tunnel first in a form chamber on both the sides. So after I formed the Chariot tunnel, made the incision, superior tunnel, and then prolapsed the nucleus. I mean, not only nucleus, the whole cataract in the anterior chamber. Visco is injected to push the vitreous down, and the whole cataract is removed in toto without any vitreous disturbance. So what I do little different from Gabor's technique is that I usually pass a suture material through the dialing hole of a rigid PMA IOL, which will act like a sling and prevent any IOL slippage or IOL drop during the manipulation. So after sclerotomy, you can see that I passed a suture material. This is called IOL sling technique, got published in IGO in 2020, and this video will make it more clear. Dialing hole, through the dialing hole, suture material either 90, 10, nylon is passed. The ends will be outside the tunnel throughout the manipulation, which will prevent any IOL drop or slippage. You can see that while taking out the leading haptic or the trailing haptic, the suture material is outside, and once the IOL is found to be centered, the sling will be cut and removed. So this is my last case where you can see that there is a nasal subluxation with wrinkling of the capsule. Here I was not fortunate enough to have a adequate continuous capsular axis, so CTR I could not implant, and as the size of as the support of the bag was not adequate, I decided to go for iris suturing of at least one haptic of the IOL, for which I have passed a Prolene suture, 90 Prolene suture through and through the iris, and the loop is taken out from below the iris, out of the eye through the tunnel, and will be looped on the leading haptic of the IOL, and after looping it, the IOL will be placed in the sulcus, leading haptic first, followed by the trailing one. And once IOL is found to be stable, both the suture ends will be taken out through the same paracentesis and will be sutured in the manner of 3-1-1. So then IOL is well centered. So to conclude, each case is different, and although traumatic cataracts are extremely difficult to manage, but with excellent surgical skill and timely management, one can prevent complications and provide better visual outcome. Thank you. Thank you for listening.
Thank you, Dr. Manas.
Thank
So, as we were discussing every time that SHS is possible in each and every situation. So, there's videos that show that we can do in complicated cases also. Dr. Niruma, you are ready?
Yes.
So, she is speaking on good ergonomics or tube mutant season in MSICS.
Good morning, everyone, and I would like to thank AIOC and ISMSIS for giving me this opportunity. No financial interest in this presentation. So to talk about the 2 mm incision with back cuts, let us go ahead with the physics of the procedure. If you look at this figure on the right down, you will see that there is an elastic lamina and a surface. The elastic lamina is the surface of the tunnel, and the roof of the tunnel and the surface is the bed of the sclera, through which you will be creating the entire tunnel from the cornea as well as the sclera. So here in the object 1 is your vectis, and object 2 is the nuclear fragment that will occupy the space of the tunnel as you are delivering through it. And it is denoted by the alphabet small d, that is the height. So in order to create this, we actually create a 2 millimeter incision 1.5 millimeter behind the limbus and placed 1.5 millimeter back cuts on either sides of the incision. Now you can see that the inner lip, that is the corneal entry, I have marked it as 3 to 6 millimeter, because there is a possibility that when you enter, you may inject a foldable IOL with a 3 or 2.8 millimeter incision into the cornea, or you can also expand it to almost 5.5 millimeter PMMA implantation. So by Hooke's law, we know that in an elastic material, when the stress is within the proportional limit, the membrane will return back to its original length when the objects are out of the tunnel. But when it crosses that, the elastic limit, it will try to fracture or reach the breaking point. So in this situation, the cornea is the plastic region and the elastic region is your sclera. So we'll take advantage of the elastic region in this procedure. So these are some of Dr. Sahu's modified instruments, and I would like to bring to your notice that Dr. Sahu's modified vectis with a 2.8 millimeter hanging edge is one of the most wonderful instruments that will help you to deliver the fragmented nucleus through the incision. So let us go ahead with the video. So I have marked a 2 millimeter incision from 1.5 millimeter behind the limbus. So you have to notice here that this is a 2 millimeter curved incision and not a complete inverted U incision. The 1.5 millimeter incisions are placed on the edges. This is done because as the incision is very small in size and you are behind the cornea, so what happens is that as you go behind backwards, downwards, the restoring force or the stress on the membrane also increases. In order to avoid that during the delivery of the nucleus, you cannot increase the thickness of the roof, that is the scleral wound. So what else can you do? You can actually create pockets on either side without tearing the main incision, that is the 2 millimeter incision. So you go ahead with this 2 millimeter incision, and then now you make an entry. The entry should be a little diagonal so that you don't tear the incision. So here I'm planning for a 5.5 millimeter PMMA optic, so I have gone ahead with almost a 6 millimeter or 5.5 millimeter optic. There are different methods of doing a phaco-fracture. Here I am using an irrigating flattened visco-tip cannula, and while doing so, I am injecting the visco during the delivery. So as you can see, there's a little stretch on the tunnel, but because it is well within the elastic limit, so the pulling out of the nucleus is easy through this 2 millimeter incision with the back cuts. So even the PMMA IOL is easily implanted through this tunnel. Now, when you analyze this, why are we doing this? You can see that the stress is denoted by the Pythagoras theorem, where K is the constant and delta L is the change in the length of the tunnel. So when there is a change in the length of the tunnel, that is your corneal entry is around 3 millimeter or 5.5 millimeter, but your scleral incision is 2 millimeter. That means you are going down, you are tapering down the incision more and more farther downwards. So what happens here is the stress force that is acting on per square millimeter of area, the restoring force keeps on increasing, and the tensile strength on the edges of the wound is more. So in order to decrease the stressing force, you have to expand it or you have to increase the thickness. Here we cannot increase the thickness in all the patients. So what we do is that we create the pockets on either side in order to decrease this stress or the restoring force on the membrane. So now coming up to the nucleus, if the nucleus is, you have fragmented or bisected the nucleus, the restoring force will also depend on the height, that is the vectis that you are using and the fragment of the nucleus. So as the height increases, the restoring force also increases. So since the stress on the scleral membrane is more near the smaller incision, you have to break the nucleus into smaller fragments. If it is a harder nucleus, make a trisection using a snare. The minimum length of therefore, the minimum length of the tunnel and the maximum size of the nuclear piece and the minimum thickness of the scleral membrane should be such that it is well below the elastic limit. Now, there is an analysis where you can pull the vectis horizontally. But if you pull the vectis horizontally, what happens is the acceleration with which the nuclear piece, and now it is sticking to the vectis, with which it is pulled, the force will be more. So if you increase the force, you will actually slip the nuclear fragment from the vectis. So here, W1 and W2 is the weight of both the vectis, as both the objects, that is the vectis and the nuclear fragment, and 2t sine alpha is the vertical component on both sides of the incision. And the cos alpha or the horizontal components are negated here. So for force which is less than this, the nucleus piece will not be able to overcome the friction and the membrane will tear up. So what you have to do is that you have to pull the vectis at an angle, a slightly more angle, that is you have to lift it up a little and then pull, so that the nuclear fragment remains in the center of the tunnel and it is easier to overcome the frictional force with the tunnel above, as well as you can utilize the cushioning effect of the sclera below. So the correct technique is to put a 1.5 millimeter back incisions, create the pockets, and it would be incorrect if you tend to do it only with a 2 millimeter incision. So we know that this gives good results in terms of astigmatism and also wound healing and endothelial cell count also. Thank you for your patient hearing.
Yeah, thank you, Dr. Lindparna. Now next we will invite Dr. Karamjeet Singh, who is going to talk about Sahu's 2 millimeter MSICS, my experience. Please stick to your time, strictly.
Good morning, respected chairpersons. Actually, my talk is made simple by the talk of the previous speaker. So, I'm speaking on Dr. Sahu's 2mm MSICS, which I am doing these days, and I am teaching to the residents also. So, most of the physics part is already told by our previous speaker. So I'm not going to the various basics of this MSICS. So why I prefer this 2mm incision during this cataract surgery? Because it has all the advantages of phacoemulsification with manual small incision cataract surgery, with minimum complications and with minimum equipment required. So I'm directly going to my video of the first case. So as Dr. Saab described, that my incision is approximately 1.5 mm behind the limbus, and it is of 2 mm. So first scleral pocket is 2 mm, then approximately 1.5 to 2 mm towards the fornix. So practically the inner incision will be, the outer incision will be 2 mm. So then dissection of the scleral pocket. So thanks to Dr. Sahu, who taught me this technique and made my life very simple in various types of cataracts. So this is as good as doing phacoemulsification. So for the sake of time, so it is very simple to dissect the tunnel, like Dr. Saab described the physics of this scleral tunnel. And I find it the safest tunnel in terms of the complications, in terms of the least surgical induced astigmatism. So tunnel is almost complete. So Rexis as usual. I mostly prefer to do from the side port. Then hydrodissection. Then after that, I enlarge my incision with, I'm using 2.2 mm keratome. So practically the outer incision is approximately 2.2 mm. So this is my way of nucleus fracture, which I learned from Dr. Sahu. Then with vectors. So you see that there is least pressure on the cornea and the scleral tissue. Although we find little bit edema near the incision line, but that subsides within 4 to 6 days. So I prefer to do foldable IOL in this case. So this is my next little bit hard nucleus. So tunnel is as usual, which I described. Then capsulorhexis. And hydrodissection. So then I prolapse the nucleus into the anterior chamber with just applying little bit force. Then nucleus fracture with the viscocannula. The tapered viscocannula. So I can bisect, I can trisect. So just 1 minute more. So then removal of the nucleus species. So with this technique, so I already performed more than 150 cases after I learned it from Dr. Sahu. So although there is a little bit corneal edema near the incision line during first few days, but it subsides within 4 to 6 days. And the patient, most of the patients gains very good vision without any complication. So I think this is the safest technique, and the results are comparable to phacoemulsification with minimum instrumentation, with minimum effort. And the learning curve is very fast. Even now these days, my residents are doing cataract surgery with this technique.
Thank you, Karamjeet.
Thank you very much. Thank you for your patience.
We go to next speaker, Dr. Rajendra Kaur Battal. We have many professors here.
Okay,
I can see.
Good.
So she will also speaking my experience with 2 mm Dr. Sahu incision.
Very good morning, everyone. And it's a beautiful morning here on the last day. I want to thank All India Ophthalmological Society and Venua Small Incision Cataract Surgery Society, Dr. Boramani sir, Dr. Sahu sir, for giving me this opportunity. And my topic is Dr. Sahu's 2 mm small incision cataract surgery, my experience. No financial disclosures. I love inspiring people, and if I can make difference in one person's life, then that's success for me. So when we learn the technique and passing to the future generation is very important, how we can pass to the future. So education isn't something you can finish. So still we are learning the newer techniques in our field. So change, but start slowly because direction is more important than speed. So when when you should think of doing 2 Sics. First of all, you should be confident with the normal manual small incision cataract surgery, 7 that is when it is a hard nucleus, 7.5 Then try shift slowly. First, change to 6 incision, and then also document the findings, that how your astigmatism is changing with the change of the size of the incision. Then, when you are confident with that, then change to 4 incision. So, I don't tell everyone to directly jump to the 2 Sics. So, transition is important. So, change to 4 first. Then, when you are comfortable with 30 to 40 cases, then shift to 3 incision, and finally to the 2 incision. So, that is 20th May last year. It was when manual small incision cataract surgery, it was introduced to us, Dr. Karamjit sir and me, by Dr. Sahu sir at Amritsar. So we feel privileged to be introduced to this technique. So Dr. Sahu sir performed, we did, I think, on that day around 8 cases, and 6 cases by sir, and 8 to 10 cases, 2 by Dr. Karamjit sir and 2 by me in front of Dr. Sahu sir, and it was live as the residents were also having a feel of it, and they were seeing it, witnessing it. So the special instruments introduced by sir to manipulate the nucleus delivery, so as to minimize the complications related to the smaller incisions, which we think that they can occur. So this is the video of my first attempt on 2 in front of Sahu sir. So incision in making and the nucleus delivery. So we can hear in this technique, there are 2 main things, the incision. The previous speaker, that is on the physics of the incision, has been beautifully covered by Dr. Nilupratna. That is how it is to be made. That is 1.5 from the limbus, and the back cuts, they are very important because they close the incision as a purse string incision, so the minimizing the astigmatism. So all the other steps, like the rexes, we all are confident in that, and making the tunnel and the delivery of the nucleus is important. So the delivery of the nucleus, how is to be done through the true incision. So the nucleus can be bisected or trisected with the various techniques. Here I am using that is bent visco cannula. You can bend with the needle holder. So no other instrument is to be bought. You can bend the that is the front of the needle of the visco cannula with the needle holder, and just you can bisect the nucleus into and other tricep. And then the delivery is, I still use, that is the superior rectus forceps, but with the experience, I think I will be able to use the minimal manipulative techniques, but I'm still exploring myself. So we can see the nucleus is bisected, and it is brought through the 2 incision. So this was my first case. The 2 cases went well. And here I want, the case which I did independently after learning this technique. So that is the mature senile cataract. So I just forward it, like making the incision. So when you are beginner, you can have a bisect in the incision on the periphery. So it is beautifully covered that how to minimize it. Your crescent can cut so you have to go around the globe, like in manual small incision we always tell. So the nucleus is brought into the interior chamber. This wire vectis should be you have to decide it. That the bigger one you have to avoid it. It is a straight with the serrations over it. So when you fix it with the that is bent visco cannula, the nucleus doesn't move. So you have to just bring on the wire vectis, you have to bring the nucleus over the that is the wire vectis, serrated wire vectis. So you can see the serrations on the wire vectis. So it is to be used, and you can bisect, and the epinucleus comes like very easily, and you can put the foldable or the non-foldable intraocular lens through this, and all the steps are other steps are similar.
Rajinder, please
Yes,
conclude.
sir. Just I am concluding. So this is the immediate post-op picture. You can have corneal edema, but it just settles within a week with the good incision. Thank you so much, sir.
Thank you, Rajinder. So we speak.
These are the few post-operative pictures. Thank you so much.
Thank you, Rajinder. So we move to next speaker, Dr. Karan is the youngest dynamic surgeon. He will be speaking on MSICS in challenging cases. I request all speakers, as we have short of time, to stick to their timings. Thank you very much.
So I've changed a little bit because Dr. Deepak was covering the challenging cases. I just decided to focus on just one aspect of it, that is the big zonules. At the outset, I thank Dr. Nilutpanna ma'am for this opportunity and the chair for it. And it's always a pleasure, to speak in front of your mentor and teacher who handled my complications when I was a resident, Dr. Manasnath. So it's a pleasure to speak in front of you, and I hope I can do justice to the topic. So a preoperative workup in such cases is extremely critical. You need to look for phacogenesis in the undilated pupil. On dilatation, look for flattening of the lens periphery and look for predisposing conditions that are pseudoexfoliation and trauma. If there's vitreous in the anterior chamber, you need to do vitrectomy first and then go ahead with the lens management. A pars plana approach is also sometimes you can go ahead even for anterior segment surgeons. So intraoperatively, be always prepared for any complication and keep your handy tools such as the CTR, the Sioneering or the CTS in hand or ready. So capsular staining is extremely important here, but it's dubious also because it toughens the capsule, but at the same time, the dye can escape to the vitreous cavity, particularly through these areas of zonular dialysis or coloboma eyes such as this. CCC is often the first indicator. It's more effortful. You can see this shakiness of the lens that is this in such cases. You can see the lens is moving, and this is when you get an idea that, this is better to do an SICS, or you need to do something, plan as if you're doing a phaco, but SICS becomes easy here. So it's always better to shift to a rhexis forceps because it puts lesser pressure on the zonules. This is another case. It's a coloboma eye. You can see finding it a little bit difficult, but it's always better you shift to a Utrata or a micro rhexis forceps, and because it makes life much more easier. In such cases, you have to center it on the lens, the rhexis. Look at this case now. Now this is a case with a coloboma, a grade 5 cataract. There's calcification on the anterior lens capsule. It's very difficult to cut the capsule. I tried this with the cystitome. I tried this with the Vana scissors. Eventually I had to go with the micro scissors. Now this is where the real advantage of SICS comes in. Phaco would have been so difficult in such a case. So cut with the micro scissors, all this, and then you can easily remove the lens without, because you need to do minimum manipulation in any surgery that you can do. So coming to a CTR implantation, I'm saying as early as possible and as late as possible, because if you're finding it difficulty, you put it early like I'm putting it here. But if you can delay it, you can see there's an area of zonular dialysis, then it becomes much more easy. Particularly cortex aspiration can be slightly difficult when a CTR is already in place. So using the two-hand technique, you have to go in, first put it inside and then use two Sinsky hooks so that it doesn't slip away. Similarly, another eye of coloboma. This is another eye. So again, I'll say as early as possible and as late as possible, you have to take the call. So the real advantage of SICS is actually the nucleus management. So you can see this is the area of the zonal dialysis. I've shown the previous steps of these two cases. The lens slightly rotated, but then I could go ahead with the vectis and take it out. And the second video, if you see, this is hard cataract. Doing a phaco would really be turbulent through the endothelium also in such a case. You can have a bag, you can eat up the bag also, so it's always better to do an SICS, particularly when the rexus is compromised. The IL insertion, you can go ahead with the routine fashion. In such cases, if you're putting it in the bag, the haptics should be oriented towards the area of zolodialysis, but if you're putting in the sulcus, you can put it 90 degrees away to it, and then you can do an optic capture. A 3-piece IL is definitely recommended over here. In case of absent capsular support, again you need to know how to make a tunnel. So iris claw IOLs is a very handy tool. It really does help in situations, and you don't have to have a VR all the time. This is another technique that we developed called the MYX technique, and we published this. So in cases where, so this has good iris, if in cases where the iris is not sufficient, you can do this sutureless technique for SFIL, and it's also got the IGO Silver Medal Award for it. So it's a combination of Yamane and the XNIT techniques, and then you create a flange and this buries intrasclerally. So I'd conclude by saying SICS is the backbone of all eye surgeries, and it makes difficult situations easier to handle. Thank you so much. At the outset, I'd like to invite all of you all to the Young Ophthalmologist meeting that we are having in Delhi, Indian Habitat Center from 27th to 28th April. Please register for it because the early bird registration closes in 2 days. Thank you.
Thank you. Thank you, Dr. Karan, for restricting to the time also.
Thank you so
Our next speaker is Dr. Rashmita, who is going to speak on DMD during MICS, why and how to manage. She's not there? Okay. Our next speaker is Dr. Deepak Megur. So he's going to show us MSICS in complex situations. His videos are treat for the eyes.
Respected chair and my friends was gathered in the early morning. I'll be speaking on a few complex situations, and what I'm learning new I'll be sharing. Maybe I'm a little bit late in learning these things, but let me share a few things which I learned recently. So posterior polar cataracts are always challenging, and we end up having this. So while doing in SICS in posterior polar cataracts, can we minimize the incidence of PC tear? That's what I was trying to study. Now this was a typical case of PSC, and as soon as I remove the nucleus, there is a momentary shallowing of the chamber, and we have an open posterior capsule staring at us. So in spite of using sodium hyaluronate, which I used to maintain the chamber, I couldn't prevent the posterior capsule rupture. We can also see the anti-hyaluronic rupture here. I pushed back the vitreous by using dispersive OVD and then wanted to do a posterior capsule rexus. Mind you, posterior capsule rexus should not be done if we have vitreous fibers hanging around there, okay? Because you're going to induce traction, and that's going to be quite disastrous as far as the retina is concerned. So ensure that there's no vitreous when you attempt it, and I'm using the side port to do so that the chamber is maintained well. Then once you're done that, then you're going to do the anti-vitrectomy. Again, using the 2 side ports, the cutter is not going to go through the main incision. And now I'm forming the chamber with a cohesive OVD so that the lens can be very easily manipulated into the bag. Now, because we have created a posterior capsule rexus, during this maneuvering of the lens into the bag, you don't see the enlargement of the posterior capsule. So this emphasizes the importance of converting a posterior capsule tear into a rexus that gives you a better chance of still placing the lens into the bag itself. So the PC tear occurs when there is a momentary shallowing of the chamber during nucleus extraction. And I was thinking, can we extract this? So this is another case, very dense cataract with a corneal opacity. And in these situations, I thought I would go back and learn how to use an AC maintainer, because Dr. Nayak is here, Dr. Boramani is here. They have been using since ages, but I would never use this. So for these special situations, I thought, will it help me? So these are my first few cases where I thought of using an AC maintainer. The other principles are same. What I'm doing is I'm using the AC maintainer. The only trick here is it's not on always, only during the nucleus evacuation out of the chamber. Now the chamber has a dispersive OVD also, and also the AC maintainer is on now. It is just started now. We don't want a high hydrostatic pressure. If you use high hydrostatic, we have demonstrated that you can have a spontaneous rupture of the posterior capsule with high infusion pressure in posteropolar cataracts. So the bottle height maintaining is extremely critical. And then the combination of AC maintainer and the dispersive OVD, I'm going to extract the nucleus out. And at this stage, you can see the chamber is still maintained. And there is, although there is a bright reflex, I thought initially the PC has given way, but it hadn't. So the trick what we follow in your phaco, that never allow the chamber to shallow, that can also be implemented and practiced when you're doing MICS, manual small incision cataract surgery, in these posterior polar cataracts, and so far it has been reasonably successful for me. So I think preventing the chamber from shallowing or preventing it from sudden deepening, maintaining the equilibrium, I think is extremely crucial factor when you're managing the posterior polar cataracts. So I'm using it on only during this step. Rest other steps I'm not using. If you don't have this AC maintainer, there's a momentary shallowing which can be prevented by this. This is something which I learned very recently. So I'm still learning how to use the AC maintainer, and now I feel that in certain situations it's quite helpful. Now moving on to my next situation. This is a different case scenario where patient has a long-standing cataract and a phacolytic glaucoma, steamy cornea, can't see the lens itself in these patients. So once you control the inflammation and the pressure, you decide to perform the surgery, and you expect a loose zonules in this patient. So in these situations, the most critical aspect is to get the rhexis right. If you can get the rhexis right and of adequate size, then you can prevent the accidental intracapsular extraction which can happen because of the lax zonules. Now the challenge is to do a bigger rhexis in a small pupil. So try to stretch the pupil a little bit. So in these situations, the most critical factor is the rhexis. If you get the rhexis right, then you have a higher chance of saving the bag. I'm trying to retract the iris with my left hand instrument, which is introduced to the side port, retract it, and then try to complete it. So I thought the rhexis was decent enough, and I could manipulate the nucleus out very well. Again, bimanual technique is something which you need to learn when you're trying to deal with these loose bags. But the shocker was really once the cataract came out, what still they look like another cataract is there inside. And what happens, the liquefied cortex can also get across into the burger space, how it has come anteriorly. So you can just leave it like that. It will get absorbed in maybe 4 to 6 weeks, but there is always some amount of inflammation which persists and all. So the other option which I try is to go and do limited anterior-vitrectomy through the pass-plan approach. Of course, for this, you need to suture the main wound. We don't want the chamber to shallow, the eye become too soft. And then I'm going to introduce my cutter. The key here is always ensure that the port is facing away from your posterior capsule, not to the posterior capsule, because there is every chance you can eat at the posterior capsule because of lack of, And you should start the cutter only once you see it in the pupillary area. And in a couple of seconds, you can clear off all the liquefied lens matter which is there in the burger space. And then you, of course, I need to suture that sclerotomy which I have done, and the conjunctiva is closed. The pressure will there, and then that's it. Thank you for your attention, and thank you for the opportunity, sir.
Thank you, Deepak. It is our pleasure to see your videos. We're still learning from your videos. Dr. Vaishali is ready by now. She will be speaking on associate through 3 mm incisions. So we are going from 6 mm, 7 mm to 2 mm.
A very good morning to all, esteemed guests on the dais and the fellow delegates. So yes, it is possible. We have all seen from 7 mm to 6, and I think I thought I was the smallest, but yes, we have seen 2 mm as well. So skipping all the introductory part. So in methods, and this was my study. It was total 40 patients of cataract was taken, and most of them were pre-senile, immature, and traumatic cataracts and soft cataracts were also included. So exclusion was hard brown cataract senile patients and patients with pre-existing corneal pathology and poor uncooperative patients who had poor general conditions. So a 3 millimeter scleral incision was made at 12 o'clock with the BP 115 number blade, and then opened with the crescent knife. Anterior chamber was entered with 3.2 keratome, and in some cases, later on I tried the clear corneal incisions also. Here I'll just show you a short video. I am always propagator of a frown incision. I rarely make a straight incision. So as we have already seen in the previous lectures about how it is astigmatic neutral and away from, so these are the incision parts. So coming to the capsulorhexis, in manual phacoprogmentation, a good mydriasis is essential, and a capsulorhexis was made with a cystitome through a side port incision and MVR blade. After the capsulorhexis, the anterior chamber was entered with a 3.2 millimeter keratome. Balance salt solution was injected, and between the anterior capsule and the cortex, so in the immature cataracts, I avoid using Bluerex dye, trypan blue, and when the glow is very properly seen, only in the mature cataracts, then the trypan blue dye is used. So coming to the main topic of manual phacofragmentation, once the nucleus is luxated into the anterior chambers, sodium hyaluronate is injected around in the anterior chamber. The nucleus is then fragmented by blurring by using two dialers and a chopper or a Sinsky hook through two side ports, and applying opposing force in the middle of the nucleus manually. Thus the nucleus gets fragmented into or more fragments and these are then expressed out either by visco-expression technique or the irrigating vectis. For my residents, I always advise them to use irrigating vectis techniques, which makes the delivery of the nucleus very easier. And in the learning phase, it is very helpful when students are struggling to get the nucleus out of the anterior chamber. And then the remaining lens cortex is aspirated by a Simcoe's cannula. So now that the nucleus is in the anterior chamber, with the help of a Simcoe cannula and the Sinsky hook or a chopper, it is manually phacofragmented into pieces, and it is then the fragmented nuclear parts are then delivered out of the chamber. So it is assisted from the side port incision with the help of a Sinsky's hook. So another case. So sometimes it is done in the posterior chamber, the fragmentation, but to avoid corneal damage. But preferably in pre-senile cases when the nucleus is very soft and there is good hypotony. And then the prolapsed pieces are then nuclear pieces are then prolapsed in the anterior chamber. I thought I still have 6 more minutes. So the viscoelastic materials is then injected, and foldable IOL implantation is done through the 3 millimeter incision. So post-operatively, corneal edema and striate keratopathy was significant in few cases, but usually it resolves within a couple of days, and these were the observations. and the results. So there's no significant differences in BCVA in post-operative patients of both the group. However, phacoemulsification leads to a lower rate of astigmatism, but there was no difference in the post-operative complications, and cornea was quite okay. So to conclude, soft nuclei can be easily manipulated through the 3 mm incision, and corneal complications are similar, and this is very shorter learning curve and no higher resources and no machine dependence is there. So PG students can be taught implanting foldable IOLs in these cases. Thank you so much for your kind attention.
Thank you, Dr. Vaishali. So now we move to Dr. Twinkle. He will be speaking on combating comorbidities, cataract and glaucoma together.
Good morning, everybody. Thanks, Chair, Dr. Mathur, Dr. Boramani, and Dr. Nayak. I acknowledge Dr. Puri Bhagat for supporting me for this talk. Cataract and glaucoma both affects on the elderly. Coexistence is either primary or a secondary. Just Dr. Deepak has already shown the one of the phacomorphic glaucoma, the phacomorphic, phacolytic, or sometimes the ectopia lentis, or sometimes the steroid-induced glaucoma. So many glaucomas are there which are combining with the cataracts. So now we go one by one, how the impact of cataract on the glaucoma evolution. Intumescent cataract, it produces the issue shallowing, it is more mimic like a PAC, primary angle closure disease. The same way, it prevents the proper opening of head visualization. Also, the visual field, which is versus the mean deviation across all the tests, all chances of artifacts, it's very difficult to find out about the progression of this, and interpretation has to be very cautiously. The same way, imaging quality, the false underestimation of the retinal fiber layer because of the denser cataracts. The other way around, the impact of glaucoma on the cataract. Cataractogenesis is faster with the higher elevation of the IOP for the longer time. Some medicines like a pilocarpine, which is hastening the cataractogenesis, which is also contraindicated posterior subcapsular cataracts. Trabeculectomy, progression of the cataract, especially in the postoperative shallow AC, plus or minus inflammations, impact on the visual prognosis, and necessitates the modification in the cataract surgery technique. Now, how to evaluate these patients who have a coexisting glaucoma and the cataract? Most important part is the conjunctiva, selection of the site before going for the surgery, because we are going to have a lab on that particular area. Antechamber depth, shallowing and antechamber, you have to go for the hair viscoelastics, retentive viscoelastic. Ciliary lenticular block is very common in these cases. And careful IOL power selections, you cannot go for the regular formulas like SRKT or Barrett one. You should go for the OfferQ or OfferQST1. Adequate BTS, especially in the patients on the myotics, posterior synechia, and pseudoexpulsion. When you find any pseudoexpulsion, it's very important to go for the dilatation, which is very mandatory, because those patients have always a poor corneal endothelium. They have a zonal instability, and you have to go for a little bit larger axis, they are postoperative capsular contractions. So in those patients who find any pseudoexpulsions, go see whether the pupils are dilating properly, and if zonal status are good, it's preferably to go for the early cataract surgery in those patients. Adequate glaucoma control before the surgery is very important. And preoperative counseling for the patients and the long-term follow-up is very necessary. That counseling has to be done. Now, proper evaluation of the glaucoma in those cases are very important. So gonioscopy is must. Large area of synechia, cataract surgery alone would not be helped significantly. Compression gonioscopy has to be done if the lens contributes to the narrow angle. If you find that you are planning for the angle surgeries, particularly eye stent type of surgeries, you have to carefully look for the angles. Pelvis may appear pink due to the nuclear sclerosis. You have to keep this in mind. Intersegment imaging, particularly angle, lens thickness, and vault if with the ASOCT, visual field analysis. Important to counsel regarding the prognosis, because that will give you a very good idea about how much the damage of the glaucoma is already there. And some was very, very dense cataract, you should document by the USG about the optic nerve head. General principle before the surgery, stop the PG analog. and myotics 1 to 4 weeks prior, may substitute with a systemic drug. Perioperative IOL as low as possible, it is very important. Avoid the large volume of the local anesthesia and the local massage. Avoid adrenalines. And if the patient is cooperative, in very advanced cases, it is better to go for the topical anesthesia. What should one do? So many options for the surgery when you have a combining cataract and glaucoma. Either SICS only and treat the glaucoma with the medication, simultaneous SITS with the trap, and trap followed by the SICS, laser trabeculoplasty followed by the SICS, or newer anti-glaucoma surgeries plus SICS. We first go for first three in this scope of the drug. SICS only. When there is a well-controlled IOP with the tolerating 1 or 2 drugs on the anti-glaucoma medications, minimal optic nerve damage is there, or ocular hypertension cases, or lens-induced glaucoma like phacomorphic glaucoma or spirophakia, as Dr. Meghur has already shown nicely about the surgery. Simultaneous SICS and TRAB, when we will go for that. Moderate or advanced glaucoma and poor control in spite of the multiple medications with significant cataract. Compliance or tolerance or affordability is an issue with the medication, or when separate or stage surgeries cannot be performed because of the high risk anesthesia or multiple health issues, or patients' visits are very difficult to have for the follow-up. So either you can go for the one-side surgery, you go for the scleral tunnel. If you have phaco with the IOL for the one-side surgery, it's more preferable rather than a SICS, even though if you are going for the SICS. Then either by the Kelly sponge, you can go for the trap, or you can open up the your tunnel and you can do a trap and suture the conjunctiva. Two-side surgery, superiorly you can go for the tunnel formation, and the temporally you can go for the SICS surgery. And then you can do a trap from the superiorly again and suture the conjunctiva. Trap followed by, just 2 slides please. Trap followed by the SICS, particularly when visually insignificant cataract need a very low IOP target. Advanced glaucoma unlikely to tolerate the postoperative IO spikes. Very high IOP, not controlled medically or causing the corneal edema, precluding safe visualization of cataract surgery, and high-risk cases where the poor prognosis, like uveitic or neovascular glaucoma or scarred corneal ocular surface. So to conclude, you have to individualize the surgery, surgeons' comfort, patients' expectations, ocular systemic and socio-economic status, meticulous planning for these cases. Cataract surgery does not cure vision loss due to the glaucoma. Combined surgery less efficacious than the trap alone, and lifelong follow-up is very essential. Thanks for your attention.
Thank you, Dr. Twinkle. Now I'll request Dr. Jatinder Bali to talk about methods of evaluation of SIA.
Good morning, ladies and gentlemen. At the outset, I want to thank Dr. Naik sir, Dr. Boramani, Dr. Mathur, Dr. Sahu, ISMSICS, and AIOS for giving me this opportunity to talk to you about statistical methods in surgically induced astigmatism. The basic purpose of this talk, I have no financial disclosures to make for this. The basic purpose of this talk is to get us to start thinking about surgically induced astigmatism, because no single method of describing it is complete in itself. Now, it was Thomas Young in 1801 who described as astigmatism, and toricity of any refractive surface of an optical system producing two principal foci delimiting an area of intermediate focus is called the conoid of Sturm. So astigmatism can be regular, oblique, or irregular, and regular can be with the rule or against the rule. And then depending on how you're going to measure it, you can use different methods. Now, people have been talking of their results. Always remember that when you're using retinoscopy, it is more forgiving, and your results are going to be slightly different compared to objective keratometry or topography. Now, the Javal's rule states that with the rule astigmatism is better, but we still don't really know whether it holds true for cataract extraction and intraocular lens implantation. Now, in 1960s, Peters suggested that, a certain degree of myopic astigmatism may be useful because what it does is it induces pseudo-accommodation in a pseudophakic patient. And then, they calculated the amount of spherical error and the amount of cylinder, which is the optimum cylinder for that given spherical error. Right at the bottom, you'll be able to see the calculations for that. It was Donders who first described the cataract the cataract incision astigmatism. And it was Cravey. He said that, it's like a hula hoop. You press one side, at 90 degrees to it, it extends. Now, that hula hoop is not just the hoop. The entire dome is going to have the same effect. So we had this, the law of the elastic domes, which has been described by many people in many ways. So how do we go about calculating and evaluating statistically the surgically induced astigmatism? The most basic one was, we used to do a simple subtraction analysis wherein we would, subtract the steepest from the flattest meridian. And it had some pluses, it had some minuses, but then subsequently, once the vector analysis came in, it became norm de Groom, and everybody started describing that. Polar analysis was, you place 0 to 180, and then the vertical ones are with the rule, the horizontal ones are against the rule. So now polar analysis to vector analysis to be converted to polar analysis requires decomposition. I'll come to that now. So different optical decomposition methods of the cylinder were described. The first one, of course, was Gartner, then it was Humphrey. And he said that, you take it at 090 and 45, 135. And subsequently, Cravey gave his own rule, the cos and sine methods. And then we came to Nasser's method. Nasser described three main methods. And the first one was, again, based on sine and cos. Then Kate, what he tried to do was, he tried to put one number to the astigmatism so that, you could compare different things. So he came up with the concept of surgical accuracy, which measures the effectiveness of your surgery. And then, of course, Nasser and Behrens came up with this 90. He says you decompose the vector into 90 degrees and 135 degrees, and then use vector analysis thereafter. What this allows you to do is use Fourier analysis, and you will realize that it is not linear. It is, a sine wave. It is a wave, it increases, it decreases. Now, this is important when we go in for our statistical analysis. Now, surgical vector is very widespread. Its adoption is very widespread. And rather than describing an outcome, it describes the process. And I have Dr. Naik here, and he's been my mentor. And basically, why is the surgical vector analysis a misnomer? Reason being that, you have the vectors are measuring the same outcome over time. And what you're trying to do in that is, people have been describing series of t-tests, right? The curves joining the means may not be a good descriptor for that. And it does not take into account the fact that measurements at different points from same subjects are not independent measures, because t-test requires independent measures. And successive measurements are likely to be correlated. Now, so what this brings us to is that, we need to have some sort of a summary measure, like peak post-op astigmatism, final stabilized post-op astigmatism, the rate of change in post-op astigmatism, and this gives you the numbers and counts. When you have the numbers and counts and percentages, that allows you to do a lot of statistical analysis. And then refraction consists of a sphere, cylinder, and axis. Again, that can be used to convert into one measure and make summary measures from there. And then we have all the optical decomposition methods that we have already talked of. And statistical methods must take full and joint allowance of all the components of refraction. And this can be achieved best by bivariate and multivariate methods. So I'll just take one. So nowadays, the main three approaches. One is Hotelling's t-square statistics for probabilistic analysis. It's a bivariate analysis. And then we have, Harris suggesting the power matrix using a W statistic with an F distribution. And then, of course, the summary measures that we've just described. With that, I come to the end of my presentation. Thank you so much, sir.
Yeah, thank you, Dr. Jitender. It is a huge topic to be just summed up in 6 minutes, so it needs hours and hours to understand this topic. Now, next I invite Dr. Bhumika.
Good morning to one and all. I shall be speaking on the outcomes of 3-piece rigid SFIOL implantation in subjects with deficient posterior capsule following complications in manual small incision cataract surgery. So we have a lot of choice of IOL placement, and SFIOLs are placed point closest to the nodal point of the eye and at a greater distance from the cornea. So our study is the only retrospective study determining the visual outcomes and post-operative complications of combined pars plana vitrectomy with SFIOL in complications of manual small incision cataract surgery in a large cohort of patients. The objective of the study is to evaluate the surgical visual outcomes of 3-piece rigid SFIOL in subjects with deficient posterior capsule in complications of SICS. This is a retrospective 4-year cohort study with participants of 174 eyes that underwent combined PPV with SFIOL as secondary surgery with at least a follow-up of 6 months. The inclusive criteria included the primary surgery had to be SICS, there had to be inadequate posterior capsular support, there had to be a nucleus drop or a IOL drop or posterior subluxated IOL which needed pars plana vitrectomy, and the patient follow-up had to be 6 months. The exclusive criteria included traumatic aphakia, patients with follow-up of less than 6 months, nucleus or IOL drop due to phacoemulsification, and any associated ocular comorbidities like vitreous hemorrhage, glaucoma, retinal detachment, corneal or scleral injury. The primary outcome measures were the post-operative best-corrected visual acuity, post-operative complications, and the secondary outcomes were post-operative IOP, post-operative refractive status, and the IOL orientation. Coming to the surgical technique, our technique was a modified Agarwal's technique that was completely like Agarwal's technique without a glue. SFIOL and PPV was done in a 25-gauge constellation vitrectomy system, and fragmentome was used for nucleus drops, and a new 3-piece IOL was implanted in every case of IOL drop. Coming to the procedure, we made a partial thickness scleral flap that 2 mm from the limbus at 0 and 180 degree. The leading haptic tip was held with microforceps and exteriorized. Similarly, the trailing haptic was exteriorized, and the tips of haptics were tucked in the scleral tunnel made by a 26-gauge needle and were sutured. Coming to the follow-up, the patients followed up at 7 days and 1 month, and then monthly thereafter. The follow-up time had to be at least 6 months, and the spectral domain OCT was done in all cases. For IOL centration, Purkinje images of the cornea and IOL was captured intraoperatively. IOL tilt, for finding the IOL tilt, the pupil is completely dilated, and separation between the posterior surface of the iris and the nasal and temporal edges of the optic was calculated. The degree of orientation and IOL decentration was calculated by the length between the nasal and temporal border of the optic and their respective limbus. This is a picture of IOL centration after 6 months. The statistical analysis was done in SPSS 26, and the pre- and post-operative best-corrected visual acuity was calculated in logMAR. Coming to the results, the mean post-operative follow-up time was 14 months, and the mean presenting age was 58 years, and there was 62.6% male and 37% female. The most common surgical indication was surgical aphakia, followed by posterior dislocation of IOL, subluxation of IOL, and nucleus drop. Coming to surgical outcome, the pre-operative best-corrected visual acuity was 20/400, and the post-operative was 20/40 or better. The mean pre- and post-operative IOP was 17 and 15 respectively. The refractive status was calculated in spherical equivalent, and pre-operatively it was 4.1 plus minus 6.2 diopter sphere, and post-operatively minus 0.4 plus minus 0.97. Coming to surgical complication, the most common surgical complication was corneal edema in 9% of patients, and followed by secondary glaucoma in 7% of patients. There was 1.1% of patients who needed IOL refixation because of IOL decentration or tilt. Our paper was published in a PubMed in Helion. Coming to the discussion, there were 174 subjects, 110, 63.2% post-operative best corrected visual acuity was 20/40 or better. There was satisfactory refractive outcome that was closer to the targeted refraction. And post-operative complications were comparative to most of the previous studies. Our study indicates similar ranges of post-operative complication as previous, and there were larger number of eyes and longer follow-up duration. IOL dislocation and suture breakdown may be present within 6 months. Most investigations only reported between 2 and 5 years after surgery. Rate of not related complication varies between studies. Our findings suggest that even existing scleral flaps do not entirely prevent knot erosion over the long term. The limitations of the study include it is a retrospective study, so chances of bias are always there. There are no control group. There is no comparison, and we have done it in a single technique of pars plana vitrectomy with SFIOL with a flap, and it needs further comparison with PPV plus SFIOL for post-operative complications of phacoemulsification. To conclude, this technique of pars plana vitrectomy with SFIOL, that is glueless, flap, and suture, is a safe technique of aphakia rehabilitation in deficient posterior capsule and provided good visual outcomes, well tolerated in long term in a large cohort of patients following complications of manual small incision cataract surgery. Thank you.
So thanks to concluding the time. We are over 2 minutes in the session. We have been warned to leave the halls immediately. So thank you all. Thank you, Dr. Phillips, sir, for coming and joining us. Thank you all the speakers. If we have time, we can stand just all the speakers, just 1 minute time.